case discussion at RWJ Medical School on the skeleton case. So, who would like to begin? Where to start a discussion on this fictional case study called the skeleton case? Particular character of interest? 'Cause I picked the movie, so there's no way you can say that the characters weren't interesting. There's no wrong answer here.
I guess we could start with Ben, the husband who's being paralyzed by the wife.
So Ben, all right. So let's start off easy. What did you see? Forget about any kind of medical jargon. What did you see?
So we saw when he was being less poisoned or sedated that he would come into these like periods of consciousness and try to escape the room, even if it meant coming out of the second story window and falling to the ground in the middle of a rainstorm.
Would it be fair to say that we observed waxing and waning consciousness? All right. So certainly at points where he appeared mute, having an inability to communicate verbally, during times where he looked like he was more awake and alert and communicative. All right. Anything else? When he was awake and alert, did he provide any self-report, any patient history? What did Ben try to communicate when he was able to verbalize his inner state?
I don't recall if he. I can't remember if they actually referred to me, but I know if he wrote like the help me on the sheet.
Okay. So some evidence of paranoia. All right. Anything else?
He tried to help someone get him away from violence, but he was like kind of like helping the same kind of thing.
Yeah. All right. So we see behavior consistent with that motivation. Yep. All right. What's our differential diagnosis? Where do you want to start with Ben? Do we think this is a mood, anxiety process, or do we think it's better addressed or approached as a psychotic dissociative cluster? No right answer. It's just us picking which path we would prefer to go down to reach our most likely diagnosis.
I would say more along the lines of psychotic dissociative.
Psychotic dissociative. All right. So if we pick psychotic dissociative, what one illness now will we choose to start from? This is arbitrary, but this is the one we've always chosen as our starting point. No, nobody watched our past videos? Schizophrenia. Right. Schizophrenia is a diagnosis of exclusion, but we first want to check to see if in fact he will rule in by noting that the patient requires 2 of 5 published criteria. What are those 5 criteria?
Delusions,
So delusions,
hallucinations,
2,
disorganized speech,
3,
disorganized behavior,
4.
and negative symptoms.
Perfect. Does Ben rule in? Taught well, right? Does he rule in? You need 2 out of the 5.
I guess kind of negative behavior, and maybe delusions that he's paranoid.
Yeah, I think that's fair. So if we look at his behavior as disorganized, and if we look at his asking for help, maybe these are delusions of persecution, and maybe he does actually have 2 of those 5 inclusion criteria for schizophrenia. Now, again, this is a condition that is a diagnosis of exclusion. So now we have to consider 5 other illnesses for which those 2 signs may actually be indicative. So what are those 5 illnesses now that we have to address and investigate? Well, two right off the bat. Which two illnesses must we always investigate before we arrive at any mental disorder?
Induced by a medical condition,
Due to another medical condition? Good.
maybe like a drug side effect.
Exactly right. So something that is substance or medication induced. Is there anything in the script of the skeleton key to suggest that this is a drug or medication induced psychosis?
Well, at the end, we learned that he's being poisoned by, or poisoned, whatever words you want to use, by the wife's name? Elizabeth, I think?
Is it Virginia? No.
What's her name?
Violet.
Violet.
We'll get it. I mean, we'll keep on guessing. We'll get it. Yeah. I mean, for Ben's case, this does look like a substance-induced psychotic disorder, right? It's pretty much well written in the script. When we look at substances that are actually published in the DSM, are there any that you might consider might be in play here? Now, I know that this, and we're going to get to this as well, this becomes a more of a culturally relevant discussion. But for the clinician that is in practice, and we have to consider those licit and illicit substances. Any one come to mind here, or any group?
I don't know what the actual, I don't know what they're called, but the ones that we use when we do like a conscious sedation for like an RSI procedure or something like that,
Yeah.
could be kind of,
Yeah, so I'm looking at the sedatives, if not the hallucinogens, right? I think they would be at the top of the list, right? Sedatives, hallucinogens. And I guess from this point, and we won't necessarily go down this tangent, but looking at the other effects, the other traits that we see manifest in Ben, we can look at whether or not those are actually traits of the medication and whether or not we could hone in on any singular agent. But I think starting at the sedatives is probably evidence-based here. Let's continue through the process just for teaching purposes, as far as a teaching didactic. Any discrete evidence in the script that suggests that Ben's psychosis is due to another medical condition? Yeah, me either. I'm going to take the pause as a no, right? Nothing in the script. And then, of course, the question that we have to ask ourselves as clinicians is, does the absence of such information allow us to comfortably say that, therefore, there is no medical condition that would account for his behavior? And the answer is no. And why is the answer no?
Just because I don't say it is absolutely doesn't make sense to like have it, I guess.
Right? And that's exactly right. Just because he doesn't say he has something doesn't necessarily mean he doesn't have anything. And there are two risk factors that would support that in terms of how strong you feel towards that. What are the two risk factors we should apply here? Age and sex. Right? If an individual who is a young female tells you that they are healthy, on board exams they are healthy. If you read that clinical vignette and you don't see discrete evidence of being unhealthy, the young female on a shelf exam is healthy. The opposite is true for the older male, and Ben is an older male. Both risk factors would not allow you to choose on a board exam perfect health. You better not. Even when the EKG looks fine and the lab results are fine, in your clinical vignette, you don't do it. And in Ben's case, unfortunately, he has both risk factors. So even though it was disclosed that this is all substance-induced, I think we should still keep that due to an underlying medical condition in our differential and high in our differential. Just for completeness sake, what are the three other illnesses beyond those two that the clinician must consider when working up schizophrenia? Schizoaffective, good. Two more.
Major depressive psychotic features.
Good. Primary mood disorder. Good. One more. Final one is an autism spectrum disorder. Those are the five. Now, with regard to GMC or another medical condition, general medical, other medical condition, and somebody can look this up for us. There is a neurologic syndrome, uh, Binswanger, something similar, BANS, that is a variant of major neurocognitive disorder with additional symptoms that I believe are manifest in the script of the skeleton key. So somebody wants to do a quick search for us.
It's found Binswanger disease.
Wagner, okay. So I forgot the end.
It's
So what do we got?
neurodegenerative disease. So it's a progressive neurological disorder caused by arterial sclerosis and thromboembolism, affecting the blood vessels that supply the white matter and deep structures of the brain, specifically basal ganglia and thalamus. Most patients experience progressive loss of memory, intellectual disability or dementia, urinary urgency or incontinence, abnormally slow, shuffling, steady pattern of walking over a 5 to 10 day period. Some other symptoms. Let's see. They can be abulic, apathetic, overall withdrawn, poor judgment, reduced planning and organization skills, and less spontaneous communication. Difficulties with speech and swallowing in general, incontinence.
Was he incontinent in the film at all? I mean, certainly, a lot of what is described is consistent with major neurocognitive disorder in general. There's just a couple things. You said something about difficulty initiating speech.
Yes.
I think that's the reason why I thought of this with regard to Ben. May have been that. Maybe it wasn't the incontinence. So again, I think medical condition will remain high. With regard to that neurological syndrome, maybe not as high, but something to consider. For some reason, I remember paranoia and the speech issue may be indicating this Binswanger. Anything else for Ben? I mean, at this point in our case discussion, we now pause, and if we took notes, we would look to see if anything on our notes page would have been covered or explained by anything we just discussed. Because if the answer is yes, we're done. But if there is stuff remaining that is not crossed out, well, we probably should consider additional diagnoses to account for that. So anything else with Ben that we really should discuss further?
Very possibly, his stroke-like symptoms are conversion disorder.
Or what?
Conversion disorder.
For a conversion disorder. So what is conversion disorder? Using these big words on me.
It's like after you walk after a trauma, you'll have like neurological symptoms that aren't explained by biological reasons.
Exactly right, right? So again, conversion disorder is a condition in which a patient will present to you with a chief complaint for which no underlying pathophysiology would explain. Specifically, the chief complaint must be in the domain of voluntary motor and or sensory function. If it's not motor or sensory function, and there are other general complaints for which no neurophysiology or physiology could explain, we call that somatic symptom disorder. So in a way, conversion disorder is a special type of somatic symptom disorder when it focuses on voluntary motor or sensory function. And in this case, that would include Ben, right? Motor function impaired. So, yes, I think if Ben presented, that's something we would have to consider. Certainly that assumes that whether it's EMG, basic lab workup, perhaps even a CT scan did not reveal any underlying pathology that would explain things, and we would assume that's the case. I think that would be one of our provisional diagnoses, of course, prior to our discovering that he's being poisoned. But I think that would be high in the differential, conversion disorder, right? Unfortunately, conversion, while it might explain his motor impairment, wouldn't explain the other signs he presents with difficulty initiating speech and communicating. Although maybe we think that might be due to conversion of muscles that support speech. All right, any other character you'd like to discuss here?
We could talk about Caroline.
Caroline, what's going on with Caroline?
So, I mean, I hate to be redundant, but we could say delusional disorder as well. She was became the caretaker for Ben. She continues to learn more things and truly believe that voodoo is real and that, you know, the people in the house are using voodoo, that the wife is poisoning Ben, that she's fixed on this thought process that's outside her traditional cultural beliefs.
Exactly, yeah. And this is a condition called hoodoo, with an H, otherwise referred to as root work, which I think it's a single word. On exams, I would hope that if they use one term, the other term is in parentheses, but you can't be guaranteed that. So you probably should know both terms. Hoodoo with an H or root work. And what hoodoo is a culturally sanctioned belief of magic, spells, and brickwork to ward off evil spirits. It is localized geographically to the Bayou region of the Southeast, Louisiana. And if this shows up in a shelf exam, there's one of two ways it is likely to show up. In my experience, between 60 and 70% of the time, the question writer is looking for you to identify this as sanctioned by a culture, or in the case of Louisiana, a subculture. And therefore, choice A, normal behavior, is the single best answer. The other 30 to 40% of the time, the question writer may ask you of the specific name of that culturally sanctioned behavior. And in the case of the fictional case account of the skeleton key, it would be hoodoo or brickwork. Now, what this movie does is it pushes the ticket a little bit, because the American Psychiatric Association does identify these culturally sanctioned beliefs or behaviors to be geographically isolated. And inasmuch they share that common quality with what are often referred to as culturally bound syndromes, right? Like amok, like atake, like kuru, culturally bound syndromes. If both sets of behaviors are geographically isolated, what then differentiates the two? The difference is that in a culturally sanctioned belief, the beliefs and behaviors are sanctioned. They're considered to be normal. Again, on your test, the majority of the time, choice A, normal behavior. That differentiates and is distinguished from culturally bound syndromes, in which it is a syndrome. It is even within the context of that culture, abnormal. And because of that, about 100% of the time, you will be asked the specific name of what is being described in that question. Amok. Brain fog. There's a list of about 6 that very commonly come up on exams. We tweeted the need to come up with your favorite cryptid for today. Anybody catch that tweet? Anybody do their homework and want to present their favorite cryptid? Really? Anybody, any interns want to post it on Periscope? I'll see which one comes up. And we may actually have the post blocked, so I'm not even seeing anything because it's probably in my settings. So that's very likely. Nobody looked up a cryptid, really? All right, well, we'll bypass this part. This was going to be the fun part of our discussion today. Anybody know what a cryptid is?
Isn't it just like
Yeah, the cryptids are classified as beings that have been reported, but that there is no biological evidence of their existence. Right? I mean, it's a very layman's term, layperson's terminology. There, I think, if you look at the classification system, there are like 6, maybe 7 different traits that would define a cryptid. But I'm trying to just give us a, overarching definition. So, Mothman's one of my favorites, by the way. I actually trained out in West Virginia, and that's a big deal out there. Anybody here see the movie? Nobody saw the movie? Okay, well, I'll leave it. What is your favorite cryptid? I'll put you on the spot.
So like the Loch Ness Monster would be one.
So the Loch Ness Monster definitely would be one.
I
Right?
don't know if that's my favorite. That was just what came to mind.
No, that's actually a good one, though.
The Jersey Devil.
Right, I mean, if you're from New Jersey, you better own that. Right? The Jersey Devil, definitely a cryptid. Right, so, and again, you could see that there's a close resemblance of cryptids and urban legend, which allows us to then kind of draw the distinction between an urban legend and a culturally sanctioned belief, and there really is no distinction. All right, so a fun way to learn some of these geographically isolated, culturally sanctioned beliefs are to look at the cryptids that are also very popular in that particular region. So you mentioned Loch Ness, that's Europe, and you just happen to pick the cryptid that localizes to a culturally sanctioned belief that was actually demonstrated not in our movie that we're discussing, but instead the Seinfeld episode we discussed earlier this morning, right? The Evil Eye, right? Which localizes to Italy and Greece, Mediterranean region. What you need to know about the Evil Eye, if it comes up in your shelf exam, is that individuals who are given the Evil Eye become ill, which sometimes does also include somatic complaints, nausea and vomiting, and children are especially susceptible. All right. So again, any movie that you see a child get sick with regard to GI pathology for which no underlying physical cause can be found, The Exorcist, consider The Evil Eye as a subversive plot to that movie.
A lot of the time in cultures where they believe in that, especially with babies, when the moms are like going for a walk with the babies, you always kind of cover them up so that no one can look at them out of fear of that.
That's right. Everybody hear that? A lot of cultures, again, primarily localized, or at least originally localized, the Mediterranean region, actually cover up the baby to make sure that nobody looks at them, just in case. Right. And that was Kramer's problem. He wasn't covered up. Okay, we're not going to go off on that tangent. We already talked about that this morning. All right, so again, culturally bound syndromes, they can appear on your shelf exam, culturally sanctioned beliefs, similar in that they are also geographically isolated, but different in that they are considered to be normal within that geographic location. And that brings us back to Louisiana. That brings us back to the Skeleton Key. So that's what Caroline's struggling with. She's not from the region. She's actually from Jersey. She's in Hoboken. And in Hoboken, she has not heard of hoodoo or brickwork. But now she does. So from her perspective, that's what's going on here. Now, we have to be very careful and especially Caroline herself, who comes to believe, if hypothetically she were to travel back to Newark Liberty, get off the plane, and begin to put down brick dust, I'm sure TSA is going to have a problem with that. But once she is transported to acute psychiatric services when you're on call, and you provide the psychiatric evaluation, I would be hopeful that you got a recent travel history, and we were able to discharge her with no further workup required, normal behavior. Despite the fact that she's not from the region, she had a prolonged stay there and certainly incorporated that region's belief system. And although the American Psychiatric Association really does not get into it, you can see that individuals who may be, for lack of a better word, susceptible would require shorter stays to begin to adopt a region's cultural beliefs. Caroline, I'm not sure how long she's there. Anybody have a timeline? we see this a lot of times with children going to college out of state. They come back for Thanksgiving dinner, changed person, what's gotten into you, brainwashed. Well, it's localized sanctioning with regard to that particular culture or even subculture. All right. Anything else for Caroline? What's interesting, of course, and if you haven't seen this movie, here's the spoiler alert, is that if she remains rigid and doesn't believe, her life is likely saved. That's the irony here. That the type of person that we don't want to be would have been life-saving here. But she actually does accept the culture that is local to her. And the twist is that because of that, she meets her demise.
Is there a character condition of being easily persuaded? Quote unquote gullible?
And what about it?
Like, would that fit into one of our conditions?
No, I just think that individual can have, it has maybe we'll call it at greater risk for developing culturally sanctioned behavior if they're more gullible. Yeah, if she were more rigid, if as a traveling nurse, as a visiting nurse, she was in that region for 1 or 2 years, maybe she doesn't come to believe because she doesn't believe in it. But whether you call it, being gullible, whether you call it being less rigid, right? I mean, interchange terms. Unfortunately, she's kind of on that spectrum towards the side where she does begin to adopt that culture's belief. And again, the irony is that actually results in the ending of this film. Any other characters? Any other cryptids?
Chupacabra,
Yeah, chupacabra. Localized where?
South America.
South America. So again, when we give this to the residents, this lecture to the residents, we actually have a world map and we localize, we find, right? Finding Bigfoot, we find the chupacabra. And when we see it in Central and South America, then we begin to discuss different culturally bound syndromes along with the chupacabra that we can discuss. And the one that comes up most commonly on exams is called ataque, or ataque de nervios, which is an individual from an identified region who presents with signs and symptoms suggestive of a panic attack, but with the distinctive quality that there is a heat sensation that begins in their abdomen and rises to their head, explaining their headache as well. So when you see panic and that sensation of rising heat in an individual who is either indigenous to or perhaps even visiting a targeted region, then ataque de nervios is your single best answer, not the chupacabra. Well, how else would it be, though, if that were choice day? Any other cryptids? All right, feel free if you want to just look this stuff up. I can't believe you guys are not into urban legends. Just tag me on your tweet if you care to share. Going on with the skeleton key, what other characters do you want to analyze?
We could talk about Violet.
Violet, okay.
I think that she's like partly like Munchausen by proxy onto Ben, and then also in that same realm, perhaps a little bit of antisocial personality disorder.
Yeah. So I mean, I think it's indefensible with regard to antisocial personality. I mean, the whole character is built in a blatant disregard for and violation of Ben's rights. So it's really difficult to say no here. Of course, if there's no evidence of conduct prior to the age of 15, then it's probably not true. Antisocial personality disorder will certainly say that she demonstrates clinically significant antisocial personality traits that still need to be treatment planned for. On the other hand, I think the more interesting diagnosis to discuss is this rule out factitious disorder imposed on another, formerly known as factitious disorder by proxy, formerly known as Munchausen's by proxy. Right. So, in this situation, we again see two illnesses that have a very common thread in that the individual is lying. One is factitious disorder, where they misrepresent their symptoms to a clinician. And there's another closely related condition in which it is defined that they misrepresent their symptoms. What is that related condition? Factitious is one. What is the other one? Yeah, malingering. Now, in 2013, the terminology was changed a bit. So psychiatry is getting away from identifying malingering as a disorder. But you're still going to hear it in clinical circles. If both of these conditions, factitious disorder and malingering, are defined through an individual misrepresenting their symptoms, what then differentiates the two?
Malingering is for monetary gain, and it kind of stops once you get that personal gain. Factitious disorder, you enjoy being in the sick role, so it never really ends.
Exactly right. Right, again, to restate, malingering, there is an identified external incentive. On the other hand, the external incentive is absent. And in the absence of that external incentive, the clinician then focuses on the internal, that is, subconscious incentive, sometimes referred to as secondary gain. That's the general idea. So what's going on in Violet's case? Is there some external incentive or not? I would say so.
To be young forever.
It's a pretty powerful incentive. So this really isn't factitious by proxy; it's malingering by proxy, which doesn't exist in the actual diagnostic classification, but certainly does exist sometimes in real life. I mean, though again, we're not going to call it a mental disorder. It does exist, and it exists in this movie. Right, malingering by proxy or malingering imposed on another, newer terminology.
Can I ask a question about the factitious on other? Do you give that diagnosis to the person who is the victim or the abuser per se?
The quote-unquote abuser has the mental illness.
And it has to be not for any sort of gain other than just being in the sick role?
Correct. It can't be for external gain. Yeah.
What about for that like Netflix show? I don't remember what it was called, about like where like this case became really big and it was that girl and I think like the mom was
Gypsy
like,
Rose.
Yeah.
what was it called?
The Gypsy Rose story.
Yeah, I
The
think
one
so.
with
Are you
Joey King.
familiar with this movie?
Yeah, I'm familiar with the documentary, the movie. So what's your specific question?
So like in that movie towards the end, they started discussing how maybe she was doing this because then they were getting like these donations and this fame and all this attention. Like it wasn't necessarily for her to be in the sick role, but they were, because of her sick role, they were getting these other things.
Like, is there ever sort of, I feel like sometimes it's kind of a combination because there are clear external gains that she's getting, like, you know, free trips, whatever, but also it could be kind of an internal thing, rising to fame as this caretaker, this great mom, yada yada. So it seems like almost, I don't know.
Yeah, the lines are definitely blurred here. So if the clinician, if the psychiatrist renders a medical opinion that the behavior is motivated by the external rewards, including the free trips, etc., it's malingering. Now the question does pop up. Wait a minute. Does that explain all of her behavior, or does some of it perhaps have to do with, or is it a function of something other than the free trip? Is there something subconsciously she's getting that is there a component of factitious? Very difficult question. It's very I mean, it's almost impossible to tease those away. Although in a court case, I am sure you're going to be asked to. So, yeah, it's difficult. And again, for full disclosure, because of the Goldwater rule, I have not personally or professionally examined the person in question. So comments today are purely speculative and based on the TV show, which may or may not be accurate, or the Netflix series, which may or may not be accurate, and are provided for mere teaching purposes, right? All right. Anything else with regard to Violet? We're good? All right, we'll end it here then. For those following at home, give us about 5 or so minutes to set up. We'll be right back via that Zoom link to present 3 cases that we have this afternoon. See you then.